Hi, I'm Dr. Kim Paxton, the Specialty Director for the Adult Geriatric Nurse Practitioner Program, and I'm going to be talking to you today about HIV diseases, some of the updates that have happened, and quite a lot about PrEP. This presentation was developed in consultation with Dr. Craig Nielsen, infectious disease specialist on the Anschutz Medical Campus and in infectious disease. So this is what HIV looks like, and I have a video for here to be able to view on your own. It's only about maybe 2 minutes, and I think it's quite interesting how HIV actually does replicate itself. Seeing this replication process will definitely help you understand the breadth of this disease and how quickly replication of it does. With respect to who is being diagnosed and the ages, also the cultural or ethnic component associated with HIV, the numbers clearly demonstrate to you the individuals who are most at risk, and those individuals happen to be between the ages of 20 and it goes all the way up to 44. The highest numbers are seen in the age group of 20 to 29, but looking at 30 to 39, they are also still at risk. And while you may not think an individual over the age of 65 could be at risk, the evidence speaks otherwise. In looking at ethnicity and culture and who is most at risk, as you can see, there is a high incidence of female gender versus the male gender. The ethnicity or cultural perspective of the individual for male shows more of a significance for the African American and Caucasian, and then for the female, more of the African American and pretty close for the Hispanic and Caucasian individual. So this is the risk category. This is the population who is at risk for acquiring HIV. In looking at the transmission, where is the risk in transmission and who are the individuals who are most at risk? Those that are most at risk are the male-to-male sexual contact that is occurring, and then heterosexual contact where the individual may or may not be having multiple sexual encounters, or they could actually be an individual who is bisexual. We don't know who has HIV. When you just look at them, you have no clue. And HIV doesn't necessarily have to be transmitted through intercourse. It can occur in multiple ways. So when we look at the risk of exposure and we actually break it down, this slide helps you gain a stronger perspective of the type of intercourse or the means in which HIV is being transmitted to another person. So take a moment and take a look at the statistics over to your right hand side. And when you look at that statistic of risk per exposure, you can see that it doesn't appear to be very high for some of the encounters, but in others it's quite significant. But as you scroll on down, take a look at pregnancy and childbirth with no preventative measures, 1 in 4 risk. So that risk is about, there's a 1 in 4 chance that the mother will transmit the HIV to their unborn child. Going back up, the female to male no condom intercourse, the female to male indetectable viral load, so on and so forth on down. Recipient and anal sex, 1 in 72, so there's a higher incidence in that means of transmission versus the vaginal sex format. With respect to, we have an understanding of who the population is at risk. We understand how the person may contract HIV, but what are the recommendations for screening? Well, the screening recommendations for HIV are actually quite broad. and they actually start at the age of 13 and go up into the high 60s. If an individual is still engaging in practices that are risky, it could go higher than 64, 65. It could be 70, 75, or 80 if they're still participating in those types of sexual encounters. In dealing with an adolescent at the age of 13, a lot of times they're coming to the clinic with their parents, and the parent is in the room. A child is going to say no if you ask them, are you sexually active, and the parent is in the room. About 85 to 89% of the time, they will say no, even if they are sexually active. It is important to ask these type of questions with the parent not in the room so that the child can speak openly and honestly and not be afraid of the parental ramifications of their parents learning that they are sexually active at this young age. There is no separate informed consent process for this to occur. It's a simple asking about the risks. If risks do exist, then obtaining the blood samples for the screening also does not require consent. It used to, but it doesn't any longer. We have what we call the Eliminate, Abbreviate, Pretest counseling, and this counseling is about safe sex practices, safe practices associated with IV drug use or aberrant behaviors such as drug use to the point that the individual does not have memory. That also includes the use of alcohol, multiple partners. Screening all pregnant women for HIV is now the standard. And a woman can say, you know, I've only had one sexual partner, it's my husband, I haven't had this. We still do the screening on these individuals as part of the preventative process. And people who are at higher risk, they will be screened every single year. And they may say, oh, I'm fine, but we still need to do that. People can refuse the screening, and then you would just document that it was offered, but they declined. If they give you a reason why, I would include that in the charting. When a person contracts HIV, these are the symptoms that they will present with. And there's a lot of them. As you can see, these actually follow typical flu-type symptoms, but they also follow COVID symptoms, with them starting with a fever. With the pandemic of COVID, HIV has kind of taken a step backwards in screening, but it cannot be forgotten because there are people who have the same symptoms as COVID-19, but they don't have COVID. They actually have HIV and they're not being tested. So it's important to make sure that when you have a patient of a fever of undetermined origin, that you make sure you run that screen for HIV just as you are going to run the screen for influenza, COVID-19, and other types of viral or bacterial infections. So the top four are the fever, the fatigue, the myalgia, and they can also get a skin rash. It's more like a red sandpapery, not really sandpaper, but a red subcutaneous rash that's kind of spread over their bodies. And this can last anywhere between 5 to 14 days in duration. So when the person comes into the primary care clinic or they present to the urgent care, possibly to an ER, they're going to complain of it feeling that they've got a really bad flu. As you do your assessment, you're going to find that their anterior cervical submandibular lymph glands are going to be enlarged, but you also may find that they may have enlarged lymph glands in their groin and in their axilla and in their subclavicular areas. When you do your evaluation and you're doing your oral assessment, if you are seeing a fine white coating inside their mouths, this would be thrush. And thrush can be present in an individual who has HIV, and it may be in an individual who has had HIV for a while, didn't know they have it, and they're moving from being HIV into AIDS. And so we want to make sure that when we see this type of presentation that we are making sure that we are not just testing for HIV, but also acquiring a viral load. Unexplained weight loss, a lot of people will complain that they're losing weight unexpectedly. We could also be thinking this person could have TB. They could also have a cancer. The headaches, the fatigue, the diarrhea. Now remember that diarrhea is having 3 to 5 watery stools a day, and it's like water coming out of your faucet. Cream of wheat, oatmeal type stool is a loose consistency stool, but not necessarily considered diarrhea. They can have a seroconversion rash, which is something that we were just talking about before. It's this red presentation. And again, the other symptoms on the bottom, which coincide with the bad feeling or the bad flu type symptoms. If you're thinking your patient does have HIV or you want to rule it out, make sure that you have done that assessment for risk behavior prior to suggesting it to your patient. Have a conversation with them. And don't just throw out there, I think you have HIV, we need to screen for it. Share with them your rationale on why you want to be testing for this. And you can say, I just want to rule it out. Very simple to do. So the screening tests that we're using now, they're sensitive ELISAs. They're HIV 1 and 2 antigen antibody combo immunoassays. We have some of the testing that does take 24 hours to get the results back. And then we're going to talk more about the rapid testing in just a minute. If one of these tests would come back to be positive, we would want to do a confirming test, which is a NAT or an immunoassay HIV P24. And it has a 99.7 specificity and sensitivity for HIV. There can be a delay in seroconversion, so you may have an individual who presents to you in clinic and shares with you that they have what they believe is an exposure to HIV for an unprotected sexual encounter. It could be from a needle use or a needle prick, and they're coming in and it's only been maybe 2 or 3 days. They are probably going to be seronegative, and so they are going to need to be rechecked again in a couple of weeks. And typically it takes about 3 to 4 weeks for the seroconversion to occur and the HIV testing to turn positive. The median is about 2 months, and it usually is about 3 to 4, maybe 5 weeks when they start having the symptoms, those bad flu symptoms. Most all individuals, per the research, will be seroconverted by 6 months if they are seronegative in the beginning of the testing process. There are quite a few different types of HIV tests. The HIV 1 and 2 antibody antigen test is the one that we do like to use because it will give us an accurate identification if this person has an acute HIV infection occurring. So they've had an exposure, they're coming into you requesting for you to please screen them. This is what our primary screening test that we will do. It does allow for earlier detection of the HIV infection, so we can catch it at that 3 to 4 week interval versus later down the line as the older tests would. The HIV-1 NAT, which is a nucleic acid test, it's going to be actually looking for the RNA that is associated with HIV replication. It is a excellent test. It is our confirmatory test. So we have a positive HIV 1-2 ABAG test. We're going to confirm it with an HIV 1 NAT. That confirmation then leads us into the treatment process. Now, the HIV 1 NAT test can also detect viral load because of it measuring the copies, which is your RNA associated with the HIV replication. The HIV 1 NAT is an extremely expensive test, so we don't use it as our screening, but we do use it for our confirmation. Then we also have the final one, which is the HIV RNA testing. This is also known as your viral load test, and this is the test that you would be doing once a person is confirmed to be positive and you get them started on treatment to make sure that that viral load is going down. We typically do not use this as a diagnostic test in determining HIV, but we do use it as a test for measuring the efficacy of the treatment process for an individual who is HIV positive. We have a couple different types of rapid testing that are being used in clinic. I have them listed for you here. One is the rapid antibody screening test. The results are available within 30 minutes. It can either be through a finger prick or through a saliva assessment. We have the rapid antigen antibody test, which is a finger prick for blood. It takes 30 minutes. And then we have an oral fluid antibody self-test that the individual can purchase over the counter, and that takes about 20 minutes. The rapid antibody screening and rapid antigen screenings, these are the two that are most prevalently being used in clinic right now. If a person would come back positive on these, we would draw an HIV 1-2 antibody antigen serum and confirm it. So the home tests are like I have here on the screen for you. These are not inexpensive. They're actually pretty pricey. I've seen them at Target. I have seen them on the shelves at Sam's Club. I've seen them at Walgreens. And they can run anywhere between $89 and $149 from what I've seen. But they are available, and it is possible that a patient could come into your clinic, tell you that they've done one of these tests, and it's come back positive. I've had a patient come in, actually had their diagnostic stick, showed me the positivity on it, and I went right to the HIV 1-2 antibody antigen. I did not go to the HIV NAT. I used the HIV 1-2 antibody just to make sure I was following protocol and that somehow the test was not erroneous. So with respect to how does this viral infection progress? And I wanted you to have a really nice understanding of that, so I listed it all out for you guys. We have that first initial period where the individual has become exposed and the HIV virus is beginning to replicate inside their bodies. We could draw the labs 2 days after they're exposed and it's going to be negative unless they were previously positive. But from that presenting exposure, they're not going to be. Then we have what we call the seroconversion window, and that window really starts happening around that between the week of 5 and week number 8. But it could take as much as 6 months for it to be complete. But between that window, the antibodies and the antigen for HIV is significantly elevated within the body, and our testing should be able to demonstrate that. Then the individual starts the acute HIV infection, where we have the detectable viral load showing up with the RNA. So we run our lab tests for our viral load and we find that our viral load is significantly high, or we happen to do an HIV 1 NAT, found that it was maybe a little bit elevated, and then you repeat it like 2 weeks later and it's like triple or double. That's confirmation that this is an active HIV infection and that the HIV itself is in the process of extensive replication and destruction of the immune system. And then we have our established. So we know this person has HIV. They have developed antibodies in response to it, and they may have a confirmatory Western blot or HIV 1 NAT, and we know that it's definitely. So when it comes to the testing, this is readily available for you on the CDC website. It's what's the process for testing? What do I do in a clinic setting? A person comes in, you are going to screen, or they come in with the complaint of exposure. We start with that HIV 1-2 antigen antibody immunoassay. Does that come back positive or does it come back negative? If it's negative, it's negative. If it comes back positive, there's a couple different ways it can be positive. And we could have a positive HIV-1 but a negative HIV-2, and they're still positive. HIV-1 is negative, HIV-2 is positive. We may run another test. It can both be positive. It could be indeterminate. If it's indeterminate, go right to your HIV-1 NAT, and depending upon the results on that, it either is or it isn't. This slide is from the CDC, and it helps you gain a perspective and understanding about what you're seeing on your lab results and what it actually means. So non-reactive means they're non-reactive. But if they have a positive HIV-1, they have HIV. Okay? If they're positive for HIV-2, it is just another type of genetic reference for that HIV, and you would treat it as an HIV infection. Both being positive, you treat it, of course, as being an acute HIV infection. The indeterminates, though, you may be catching them right at the point where the HIV virus is at the beginning replication, but it hasn't done it all the way. You would want to make sure you retest to make sure that A, it doesn't go back to negative, or the next option would be that it actually turns out to be an acute HIV infection, and we need to send them on or begin a treatment for us. This is what it looks like when a person first becomes infected. So the HIV and viral load begins to accelerate within the human body, but notice that the antibody and antigen is quite low. Going over months, the HIV virus will overtake the human body immune system, leading into AIDS, and AIDS is the autoimmune component of it, where the body isn't able to fight off opportunistic infections, and people typically will acquire opportunistic infections when they get AIDS, and they ultimately are what lead to the demise of the individual. The HIV antibody begins to rise typically between that week number 4 and week number 8. And as the HIV antibody begins to rise, our CD4 T cell count begins to fall, because remember, the HIV utilizes the CD4 T cell, the CD4 lymphocyte cell, as its source of replication material to replicate itself. And as the CD4 count begins to fall, the HIV viral load begins to accelerate and rise. So the picture I just put up for you demonstrates the testing, and when the testing would begin to show these types of changes through the blood. So the Western blot used to be what we used in the past. We don't use it as much anymore, but we are using the P24, the IgM, and the IgG, which is your HIV 1-2. But notice that that's not going to start turning to positivity until about day 25, day 30. But the HIV-1 NAT, at about day 15, you could actually start seeing positive indications from that test. And again, remember that the NAT is very expensive, and we don't use it as screening. We use it as our confirmatory tool. And then we have our IgG sensitive, and that's going to take almost a month and a half for it to be showing positivity. So in the treatment of HIV, we never do monotherapy, ever. It is always a combination therapy of a couple of the different types of HIV medications. We're going to talk about those in just a few minutes. Making sure that the patient understands that this treatment is not going to be for a month or two, but that it is going to be for the rest of their lives in order to suppress the viral load of HIV. It does require lab monitoring. In the beginning, it's more frequent, and then as the patient becomes stabilized, that becomes more spread out. You do need to educate them on preventative health measures and making sure that they are up on immunizations and their screenings. And mental health for this population who are diagnosed as positive is extremely important. Getting the diagnosis of being HIV positive is emotionally beyond difficult because people look at the mortality of HIV and how their lives are going to change because of it. Before we had the type of medications that we have currently, people who were diagnosed with HIV believed it was a death sentence, but it isn't. We have people who are now living between 30 and 40 years having HIV, but their viral load is indetectable and completely suppressed, which is where we want our patients to get to. So the lab monitoring that you would do in a person who is HIV positive and you are going to start them on medication, we need a CD4 count and we want to repeat that every 3 to 6 months. In the beginning stages of treatment, we're going to go more frequently than not. So we're going to do 3 months, then another 3 months, and at the 9-month marker, the patient may be showing stabilization or they may not. And you may need to continue that 3-month monitoring. We need the viral load. We need to do resistance testing at the onset of treatment. We need hepatitis B and hepatitis C testing at the beginning. We need a BMP. We need liver enzymes. We need a CBC. Fasting lipids at the beginning because the anti-HIV medications or the antivirals that we're going to be giving the patient affect cholesterol and they begin to rise in treatment. So you want to make sure you're monitoring that. And the same with the hemoglobin A1C. The medications have a tendency to cause elevated glucose levels, and because of that, we need to try and stay ahead of that, working with the patient for prevention, lifestyle modifications, and or instituting medications to keep the glucose levels down. There are quite a few resources that are out there. We have the HIV warm line, which is medical consults where you can call, talk to a medical provider, describe the patient, receive consult on what's the best to do, what would be the best treatment. We have local infectious disease providers that we're able to contact Monday through Friday, and then we have the online AIDS info by the government. There are 2 or 3 of these type of clinician-to-clinician websites that are available. There is no cost to you, the provider, to contact them. This one happens to be out of UC San Francisco. But here at UC Health, we actually also have a refer your patient. There's a doc line where we can request information from in a consultative way from specialists in different types of fields, including infectious disease. Don't hesitate to use these lines. They're there for the purpose of helping you as a provider help this patient. In working with an HIV patient, it is a collaborative management. A lot of times, a primary care provider will refer that patient to infectious disease for management of their HIV infection. Primary care can prescribe and begin the treatment of HIV in the primary care setting. It depends upon the individual's level of confidence and education. It is not a bad thing to refer the patient into infectious disease, and in speaking with infectious disease specialists on the Anschutz Medical Campus, they actually would prefer it if we as primary care providers would refer these patients in. And the reason that was shared with me is that there is a significant amount of this collaborative management that needs to occur that is not able to be done strategically in a primary care practice where they can connect them with social work, mental health, with that provider, infectious disease wise, and starting that treatment, and then financial resources because the medications to treat HIV are extremely expensive. And those are some of the reasons why. The health promotion aspects that in the primary care arena we need to keep up on are the patient's vaccinations, especially the preventative ones, pap smears, both anal and cervical smears, detecting any type of cancerous lesions and or other pathology, working with smoking cessation. Unfortunately, the population that is highest at risk also has risk of greater use of substances, so substance abuse screening, and then working to help them understand the importance of lifestyle modification to optimize the health of their bodies and reduce the inflammatory effects that this disease process elicits. There needs to be a very strong monitoring adherence, both by the provider and by the patient's understanding that we're going to start you on these medications and we are going to need you back at X period of time frame. Monitoring for toxicities. These medications that we're going to be prescribing, these antivirals or antiretrovirals that we'll be prescribing, there are toxicities associated with them. They can be neurologic, they can be effective of the CBC and the bone marrow, they can affect the liver as well as the kidney. So being aware of the monitoring and why the monitoring needs to occur and then informing the patient is really important. In looking at the patient's history, we need to understand what other types of infections they may have had. The hepatitis B and C is very important. Any STDs that they've had, TB screening should occur. And have they had vaginal candidiasis? Have they had oral? Pregnancy, are they currently pregnant? If it's a gentleman, are they sexually active at this time? And are they using a condom or not? Are there any skin lesions present that could potentially be Kaposi's sarcoma? Are they having any neurologic changes occurring that they have no reason why they would be there? Any unexplained symptoms that they share with you as you do your review of systems? And are they having recurrent bacterial infections? Bladder infection is a perfect example. Or they have a recurring integument abscess. These could all be indications that their immune system has been compromised, and that compromise could be HIV. In continuing on with preventative care, we must assess risk, and this has to be done on an individualized basis. Not every patient is going to be the same just because they're having sex with a man or sex with a woman. They're individuals, and we need to address it as such and learn and understand that particular individual. It's really important for us as providers to establish a rapport with the individual. No judgment. Explain the need to know. Here's why I'm asking these questions. Here's why related to this. Make sure you give that explanation. Be simple. You don't have to be complex in asking the questions or framing them. And then normalize the question type that you're giving. Some people have sex with other people, not necessarily your same gender. Is this something that you do? Keep it neutral. Open the door. Your body language and your nonverbal is going to communicate to that patient your beliefs and your comfortableness with having an intimate discussion in relationship to intimate activities. If you're uncomfortable, it's going to communicate to the patient, and the patient is going to sense that, feel that, and that could close the door a little bit. And make sure that when you are seeing these individuals, that you periodically ask them about, has anything changed? Kim, I know that you have sex with women. It was from our last visit. Is this still your current practice? Have there been any changes with that? Because I could go from having sex with women to being bisexual. And unless you ask me, which changes my risk profile, I may not share that with you. And a lot of times, information that we need to know isn't shared because we, as the providers, don't ask the question, or the manner in which we ask it is judgmental and off-putting. With respect to behavior change, knowledge is not necessarily going to lead to safer behaviors. So telling them you need to use a condom is not going to work. Telling them don't share your needle, it's not going to work. Don't do drugs, it's not going to work. It doesn't work. We've been doing this for decades and it hasn't changed the behaviors. What does change the behavior is peer influences, being open to understanding the patient's why, meeting them where they're at, and continually to support them each time that you encounter them. Individuals engaging in risky behavior prefer to listen to and look to role models who are similar to themselves. So they will look for that role model in an online format, in a social media type format, not necessarily from you. That's why the peer support groups are really important and they are advantageous in helping a patient because they're similar. She may look clean, but really is she? You cannot tell just by looking at an individual what their sexual preference is, what disease processes they may have, or if they have a contagious infection. You can't tell by looking at them. So when we institute an HIV risk assessment and we open the door and ask the questions, we're able to discuss risky behaviors openly with a non-judgmental view, letting the patient know the reason behind that is about prevention. And if there's a risk there, that we identify it and that we evaluate the patient to make sure that they're okay. So we really need to work with that, and it starts with us. The patients are doing it. We're just not meeting them there because of our own uncomfortableness. One of the reasons that we need to do this early risk assessment for HIV is to get that treatment started early. The later we start the treatment, the harder it's going to be to override and reduce that viral load. We're able to then help that person see that some of the behaviors that they're engaging in may be ones that are contributing to other types of risks that they may have. We have a lot of opportunities as primary care providers, and these opportunities we can either embrace or they're going to pass us by. Embracing them is what we should do, and again, that embracement is done through a non-judgmental manner. So you don't do drugs, do you, Kim? So I don't do drugs? Did you just tell me I don't do them, but I actually do? You need to, we need to change our framework of how we ask our questions. So one of the questions I'm going to ask is related to your social history, and this is just to help me get an understanding of where some risks may lie or what I may be needing to look for in relationship to a disease process. By chance, have you ever used or have you ever tried or are you currently using? And then you ask your questions. Again, non-judgmental. And share with them the why. It's part of your social history. It helps me develop that strong plan of care so I know how to help you or I know how to look for something. It's along those ways. And patients want the information but don't necessarily get it because of us. We may not feel comfortable in asking the questions that would give us the answers that would provide the information to the patient. We have to get comfortable with this. So when do we really ask about risk? We've already talked a little bit about who's at risk and when we should start asking it, but let's get down into the nitty-gritty. all new patients that are new to your clinic, so they're establishing care. You want to make sure you ask them. And periodically, so they come in for their yearly physicals every year, go back over that social history. On people who have symptoms, anybody with a blood exposure, and this could be from risky behavior or occupational. If they have substance abuse or have substance use, if they have sexual behaviors and they share with you that they have had multiple sexual partners or that they are having sex and they're bisexual, you want to make sure that you're asking the questions about safety. And if there's other types of history present in relationship to this individual, you want to make sure you get it down. So what other types of pertinent health history would you be looking for? HIV, hepatitis B, hepatitis C, frequent treatments for STDs. They have an infected abscess in their antecubital, or they've got an abscess, several times they're getting abscesses on their buttocks or things. Those things shouldn't be happening at all. Something's happening to have this happen. I had a young female that I was caring for. She was 20 years of age and she kept coming in with these horrendous vaginal infections. And then when I was doing my speculum exam, I kept finding that the vaginal wall had these small lacerated cuts, not deep, but they were there, definitely part of the causative problems that she was seeing me with. I believe it wasn't until her third visit with me that I finally asked her about intercourse and what was occurring with intercourse that could potentially cause these cuts. And then she shared with me that her boyfriend had his penis pierced with 3 different types of piercings to increase his sexual arousal, but they were lacerating her vagina. I hadn't even thought to ask that type of question, but on the third time, I I knew that there had to be something happening. I don't know if it was part of their foreplay and maybe a device was being used. I did not expect to hear that. But again, I needed to ask the question, so I had to normalize the question, make her comfortable so that she would share with me what was happening. And then from there, I was able to work with her and develop a plan of care to help reduce these frequent vaginal infections that she was getting that were pretty nasty, actually. So when a person does have a history of substance use, it's important for you to make sure that you're assessing their mental health along with it. A lot of times an individual is going to use substances because they are using them as a means of coping. So, for instance, somebody who's using marijuana every single day and they're calling it recreational, how many times a day are they using it? How much are they using it? Is it mixed with anything? Are they ever able to go a day without using it? You're trying to gain an understanding of their why and underlying components. I've listed here to your right a really great image that helps you gain a perspective of those that are most at risk with mental health disorder and the potential of acquiring HIV. And as you can see, personality disorders, bipolar, and schizophrenia are ones that are rated highest. I thought this was a great sign. Chlamydia, capital of Canada. And this is actually from one of the cities in Canada. I think it was just outside of Banff. But yeah, they were so excited to be able to call themselves the chlamydia capital of the world. Things we don't say, as we were talking about before, you don't use drugs, do you? This is me telling the patient my belief. We don't do that. We don't say that. Same thing about sex. You don't have sex, do you? Would you consider yourself to be promiscuous? That's my judgment coming through on and how I ask the questions. You haven't been unfaithful, have you? And again, it's judgment. We have to release this judgment that we we place on the patients, and we need to be able to ask these questions. Would you please be able to tell me about the number of individuals that you have intercourse with? That's making it non-judgment. You're asking them to tell you how many people they have intercourse with. Oh, just my wife. Okay, we're good. You're married, then you aren't at risk for HIV, are you? And again, statements, these are real statements that I have heard providers say, that were shared with me by Craig, that he has heard providers say, and these will stop a patient in their tracks from talking to you. Don't say these kind of things. So we really need to work with those open versus closed questions. Are you sexually active? Share with me a little bit about that. How do you get your needs for intimacy met? I love that one. And how do you clean your works? And these are the works happen to be devices that people may use um, for sexual pleasuring. If they're not clean, they can transmit from one individual to another. Substance use, ask about that. That's part of our social history. Have you ever injected drugs? When I ask patients about their marijuana use, I'll ask them about marijuana, how much they're using, and then I'll go down the list. Have you ever tried or ever used cocaine, heroin, PCP, Colorado magic mushrooms? I'll just go down the list. And if they say, well, yeah, I've tried, I'm going to ask them, when did you try? How long did you try for? And how much were you using? And then they'll say, well, why do you want to know this? And it just gives me an understanding of risk for you, but it also helps me understand different disease processes or different types of medical problems that I may need to look for. And if you say that, they're going to be okay with that. So absolutist statements, we were talking about this previously, just say no, it doesn't work. Don't use drugs. You must use a condom every time you have sex. Sex is so dirty, nasty, awful. I didn't say that one, but Craig heard somebody say that one. Um, Patients are going to completely turn away from you. You just lost any momentum you had with them when these kind of statements are made. For the condom one, do you understand that it's important to use a condom to help prevent transmission of infections to another individual and to protect yourself? And they're going to say yes. And if you say, well, you know you're supposed to use that, right? They're going to say yes again. You need to use it every time. They're going to turn right off of you. Understanding and assessing sexual behavior. Again, it's how you ask the questions. It's the mode of you setting the stage for the patient to trust you by how you've phrased other questions that come before that. And sexual activities, again, take it down. People enjoy different types of sexual activities such as anal and vaginal sex. Is this anything you've ever tried? Again, you're just questioning it, saying, you haven't tried this, have you? Or have you done this? And again, your intonation of your voice and how you say things is also a precursor to how that patient is going to interpret your belief, your judgment. So, how old were you when you first had sex? How many sexual partners have you had in the last month, the last year? And you can preface this, especially when you're in the social history and you're talking about sexual history of the individual and if they're sexually active. Start it off by asking them, are you currently sexually active? They're going to say yes or no. And the prefacing is, I'm going to be asking you a lot of questions related to your social history. Some of these are going to be including your sexual preference and the act of intimacy or the sexual acts. And this is just to give me an understanding of, again, preventative measures I may need to look at or different types of medical needs you may have or assessments that I need to do. Share with them on the front end why you're asking these kind of questions. It literally opens the door for you. The extent of protection, have you ever had sex when you were drunk, stoned, or high? I worked in a drug rehab center for about 2 years, and you get pretty ingrained into making sure you're asking these type of questions because a lot of times the individuals engaging in risky behavior when their senses have been dulled to the point that they don't even remember. I remember caring for an individual and I asked him, have you ever passed out, found yourself in a place that you didn't recognize? He goes, well, not that I didn't recognize, but with women I didn't know that were naked. And that right there gave me what I needed to know. Did you, and then asking, you did not know these women? No, I had no clue who they were. And did you have sex with them, do you think? I can't remember, but probably did. And you ask the questions, they'll answer them. But again, it's your manner of asking your questions. So we're going to go into PrEP right now, and we're going to go into NPEP. And PrEP is pre-exposure prophylaxis. So we want individuals to be using medication before, so prophylactically, so that they don't acquire HIV. And then we have individuals who have had an exposure because of something and they need to be treated. So just to give you an understanding of how PrEP is growing across the United States, these are the two images, one from 2017, one from 2018. And as you can see, this is really expanding in a positive way across our nation. But as you can see, going down the center of our state, the Midwest, so North Dakota, South Dakota, Oklahoma, Kansas, still at higher risk. There are some aspects of Colorado that are still at risk, and Wyoming, but much better than what it was in 2017. This is that same chart, and this is from AIDS View. It's an online program, and I put in the rate of males using PrEP in 2018, and this is what the chart pulled up. Comparing that to what you just saw, this is vastly different. So the chart that you previously saw, that was all individuals of all types lumped together. This is just males, period, and not ethnically or culturally based. And as you can see, there is definitely a need. California seems to be doing the best. So is Washington, Upper Washington, our general Denver area, and going up towards Fort Collins looks pretty darn good. So does the Western Slope, and Florida and our Eastern Seaboard. But some of the other areas definitely have great deficits. So there is a need for this. So what do all these mean? Well, PrEP means pre-exposure. PEP is post-exposure. And NPEP is a non-occupational post-exposure prophylaxis. And we'll talk about each of these. So when we talk about PrEP, who are we going to talk to and who is the population that we want to make sure we're giving this to? These are sexually active men having sex with men, heterosexual adults and female who have a high risk, people who are using injectable drugs, and discordant couples. Our single biggest risk for HIV is the men having sex with men population who also are using substances, especially the methamphetamine and cocaine categories. As a primary care provider, you are able to prescribe PrEP. You can. And it is actually wanted that you do this. Ultimately, why are we prescribing PrEP? Because we're trying to reduce the risk of HIV transmission between individuals at higher risk. We want to prescribe meds that are safe and effective for an uninfected person. And in order to use PrEP, they have to be uninfected. And we're going to talk more about that. Your patients do need to be educated about the risk reduction. We need to provide them with information about medication adherence and what you we'll be doing monitoring them, have a discussion about effective contraception, and we know about saying, well, you need to use a condom because that isn't going to go very far. And then we need to be monitoring these people who we do start PrEP on for potential seroconversion. There are toxicities we need to watch for, and if there's any change in their risk behavior. There are 2 approved FDA medications currently on the market. One is called Truvada, and the other one is called Descovy. Both of them are using the first ingredient of M-tricytidine at 200 milligrams. And then the second medication, the tenofovir, this one is a little bit different between the 2 of them. Both in the same family, but a little bit different. So you will see over to the left, I've put the acronyms that you're going to typically see these listed under. They're TDF and TAF. They're both nucleoside reverse transcriptase inhibitors. These are type of antivirals that are used specifically in treating HIV. We're using this to prevent HIV from occurring in an individual. So when we start a person on PrEP, we need to first rule out that they have HIV or hepatitis B. So we have to rule that out before we would start them, because that is a contraindication. If they have either HIV or hepatitis B, it is a contraindication for this. We need to assess the risk, especially within the last 6 months. We need to find out what type of sex that they have been having. For women, we need to be doing the same assessment that we're doing for men with the type of intercourse they're having. Remember that there are different types of intercourse devices that are used, and they can be used both vaginally and rectally for stimulation. How were they cleaned? Are they cleaned between sexual acts? Are they shared among people? It's very important to gain that perspective because that is how transmission can occur. What other past history do they have for sexually transmitted infections? And is there any history of that substance or alcohol abuse? Because that is going to increase their risk. Men having sex with men is one of the predominant indications for prescribing PrEP, and it is the one where we're seeing PrEP prescribed the most. They need to be without an active HIV infection, so you do need to run this screening with the HIV 1-2 ABAG. Comes back negative. That is a wonderful thing. That's exactly what we want. Again, we need that history. Have they had sex with anybody in the last 6 months? Male partner. If they're not in that monogamous relationship, their last HIV test, if that was negative, great. If you have an individual who's in a monogamous relationship, you still do need to test them for HIV. Unfortunately, we can't just take them from their word that, oh, Joe's clean. He doesn't have HIV. We don't know that Joe is clean. We have to make sure. And the reason is for the patient's protection, because if they would have HIV, they are at risk, and starting this medication could actually harm them. So we need to know, do they have any of those top ones? And then they have to have one of the following. Have they had any anal sex without a condom? Any STI diagnosis or report in the last 6 months? And in an ongoing relationship, is their partner HIV positive that they know? So we have to ask at least one of these questions, or you could ask all 3 of them. A lot of the EMRs, when we're asking these PrEP questions, the design of the program has them embedded where you just ask them and click them away. Some do not, so you may have to have them memorized and then actually write them into your note. So in prescribing PrEP for heterosexuals, same criteria that we have for the men having sex with men, but we have to ask the following. Is one male who has sex with both? Are they bisexual? What is their condom use? And it's for females. Have they had any infectious diseases, or have they been having sex bisexually with infrequent condom uses? So we want to make sure we're asking these questions. There's a way to frame these questions. So tell me about your sexual relationships. I'm trying to gain perspective on your risk. And you should be able to gain that in information that you need. Sometimes you may have to do a little bit of coaxing. Um, when I'm asking these kind of questions, I ask about um, what is your sexual preference? They'll tell me, oh, I'm homosexual. Have you ever engaged in any bisexual acts? Oh, no. Or, oh, yes. And then, when was your last encounter? And you can go from there and slowly tease out some of this information. Um, Individuals with drug use, which is the IDU, we need to make sure that they don't have an acute HIV infection, especially if they've been sharing needles. We want to make sure of what type of paraphernalia they're using. Is it always clean? Is it not clean? Have they been on methadone in the past, bupropion, Suboxone in the last 6 months? And what is their risk of sexual acquisition? So in other words, who are they having sex with? And we need to gain that understanding. And it seems like we're being invasive, but what we're really doing is trying to gain a very strong history to understand the risks associated with these individuals. So when we're initiating PrEP, we need to discuss the preventative options. And PrEP is just one of the options to help a person not contract HIV. The other interventions are behavioral, safe sex practices, using that condom. In serodiscordant couples, making sure that we understand that treatment for one individual needs to occur or the other could acquire HIV. So the initial prep labs that we need to do as providers are fairly similar to what we were doing when we were starting somebody on HIV medication. So we want to screen them for HIV and hepatitis B. We want a CBC, and you can do it with or without DIF, and that's to rule out any current bacterial infection. Renal function, because the meds are that reverse transcriptase, and they do affect renal and liver. We need a baseline lipid panel. Get a UA. We want to be monitoring for that protein, which would tell us that we are starting to have some renal involvement from the medications. We need STI screening, so we need to screen depending upon their sexual act. So if they're having a lot of oral sex, you want to make sure you do an oral swab. If they're having a lot of anal sex, you need a rectal swab. We need to check a urine for GC and chlamydia, and we need to make sure that we're doing a syphilis testing. Pregnancy testing on all females of all ages, of childbearing age. Just because a woman may be postmenopausal does not mean that she is not at risk. And a lot of times when they're just entering into menopause and they're at risk, they can become pregnant. Remember that you have to be 1 full year without a period before you are considered menopausal. With CBC, we're trying to look at for any infectious state. We want to make sure we're looking at any types of infections that they could have had 30 days prior to their visit with you, asking them about symptoms they may have had, specifically looking to see if there could have been any conversion or any suspicious illness that could be associated with viral type of symptoms. For the renal function, we want to make sure that we've got a creatinine clearance and an EGFR that are both in the normal range and that the individual is not on medications that could potentially undermine their renal function. If they are, you would want to check them more frequently than some of the guidelines are initiating, but we're going to talk about the frequency in just a minute. We want that hepatitis serology. We really need to understand if they have active hepatitis. Now, hepatitis B is important. Now, PrEP can effectively treat hepatitis B, but it also could cause a person who has latent hep B to become active. So we want to make sure we know where they're sitting. And if the person is a negative hep B, we definitely should offer them immunization for hep B. When we're prescribing PrEP, we do not substitute our own ideas of what PrEP is with two different types of reverse transcriptase medication. We don't do that. We have to use what the FDA has approved for this type of treatment. We only will prescribe 90 days of medication. There must be no refills. And it must say on the label when you're prescribing it, take one tablet every 24 hours, not daily, but every 24 hours. We don't have to do any dose adjustments with bupropion or methadone or any type of birth control at all stays the same. Other antivirals, such as the aminoglycosides or NSAIDs, may require some reduction, but we have to base that on our renal monitoring and what the renal values will look like. And we may not know that in the beginning. We'll find that out when we start doing return visits with the patient. The actual time to achieve protection associated with PrEP is really not known. But we do know that it does take about 20 days for the medication to actually start showing changes within the blood. 7 days in the rectal tissue, 20 days in the cervical vaginal, and we don't know about the penile tissue. When people start PrEP, some of the side effects they could have are a mild headache. A lot of them will feel nausea for the first couple days and some increased flatulence. And this is actually known as startup syndrome. It does mirror some of the symptoms that people have when they have first contracted HIV and the viral load is increasing. This does not cause viral load, but it does affect the body. When we place people on PrEP, they need to follow up with us every 3 months, and we need to be monitoring them for HIV status, so we need to get an HIV screening. We need to be checking them for sexually transmitted infections, checking their renal and liver panels, and then making sure if they're a female that they're not pregnant. Everything looks good. We can refill their prescriptions again for 90 days. And I'm going to reiterate, we do not give them 90 days plus one refill. They have to be back in to see us every 3 months to check the status of the labs I have over on the right. People can be This is a preventative agent, but if the patient does not take it as prescribed, they can acquire HIV. And it's really important that we catch it because the treatment for active HIV or acute HIV is vastly different from this prevention. So with this follow-up at that first follow-up, we could potentially do virtual if we needed to. A lot of patients prefer that in-person visit with their provider because they want to be able to talk to them. They want to talk about those concerns. We want to make sure we're checking that eGFR and that creatinine clearance to make sure it's appropriate. If we start seeing declines in the creatinine clearance, we may need to send this person over to nephrology for consultation. And again, we need to do STD checking on everybody, and this includes adolescents. 13 does not mean that they're not sexually active. It's just an age and a number. For long-term follow-up, we have to make sure that they are adhering to the medication, that they're taking it every day. If we get a patient who seroconverts, we know they didn't do that. The patients typically are honest with us and will tell us that they are. Over a long period of time, 3, possibly 4 years, there could potentially the development of osteopenia. So these individuals could potentially need a DEXA scan. You wouldn't do the DEXA scan prior to starting them on PrEP because there really is no reason to do that. But if they stay on the medication for any length of time, we would need to do that. And again, therapeutic drug monitoring, we don't have to do. We have to monitor the systems of the body that can become affected by the medication. So as we're doing our monitoring, remember that we do need to check and make sure the patient does not become HIV positive while taking their PrEP. In the beginning, we need to confirm what their status is. If the person does convert to being HIV positive, we would stop the PrEP and we would start following the algorithm for somebody with acute HIV. So we would start again that evaluation of their labs through the HIV testing mode. So HIV positive, we want to go to the HIV one, make sure where they're at. We need that CD4, the HIV RNA. We need to also make sure we run the tests for the genotyping for evaluating any resistance to medication. You could begin treatment of your patient in your clinic if you chose to, or you could refer them out to infectious disease for care. If the person does seroconvert and they turn into HIV positive, that does automatically trigger an automatic notification to the health department, and there would need to be contact with the person's sexual partners to them to be notified that they could already know. People can discontinue PrEP if they choose to. A lot of people will do that because their life situations have changed. They don't tolerate the toxicities of them, that nausea and the headache. They have chronic non-adherence, and when they talk to you, they tell you, well, I just can't remember to take it. That puts them at risk. So if they're not taking the med as prescribed, it is something that you have to have a discussion with them about. If they become HIV positive, is a definite discontinuation of PrEP. In the medical record, we have to document their HIV status at the time of discontinuation, why they're stopping it, and med adherence and reported sexual risk behaviors so that we have an understanding of where they're at, what they're doing, to be able to continue planning their care. There are some special populations that we need to take into consideration when we talk about HIV and we talk about PrEP, and that is your adolescents. Please don't, because of age, believe that they're not at risk. They are just as much at risk as a 20, 30, 40, 50-year-old individual. We need to make sure that if an adolescent is engaging in risky behaviors, that we are initiating HIV monitoring on them. They have to consent to it, though. You can't just do it because they're an adolescent. They have to consent. There are quite a few laws, and they vary by jurisdiction and state, so you do need to know the laws of your area and what you can and cannot treat in relationship to adolescents. PrEP is labeled for adults, but there is no real definition of what an adult is. So your adolescent time frame, you can definitely consult with a pharmacist on that or refer them over to infectious disease for pediatrics. Here in Colorado, the infectious disease clinic at Children's Hospital is amazing, and they do a lot of work with children who are at risk. Safety of bone development for children, if they do happen to be HIV positive and are placed on these medications, is something to keep in mind that would need to be monitored for. And again, you have to look at the benefit versus the risk of potential prescribing of PrEP in an adolescent. For pregnancy, anybody who's at substantial risk, and if their partner is HIV positive, pregnancy is a risk factor in itself for an individual, especially if that pregnancy occurred through a risky behavior. PrEP can be used pre-contraception. It is unclear on the risk to the fetus at this time, but we do know that the use of the reverse transcriptase medications are used during pregnancy. So it would be believed that the benefit versus the risk would be outweighing that. And again, depending upon what your provider status is and what type of care you are delivering, this may be something that would be referred over to infectious disease or into a high risk neonatal specialist. So those individuals who have hepatitis B, if the screening is positive, we can refer them over to the specialist. The use of our two agents to treat using PrEP actually work against hepatitis B. So if they had hepatitis B, these products could actually help them. There's a lot of concern of primary care providers prescribing these medications for PrEP, and the patient has hepatitis B. They're not being prescribed for hepatitis B. They're being prescribed for the prevention of HIV and the medical legal concerns for that. And that is completely understandable. In those situations, the best is to refer them over to an infectious disease specialist because they have a greater knowledge base on how this patient should be managed and treated. If PrEP is no longer indicated, you still need to continue evaluating them for their hepatitis B treatment and its effectiveness, especially if they started an ID and came back to you. Putting people on these medications for PrEP, they may have a latent HIV, hepatitis B infection that can actually become active, and they would then need treatment for that hepatitis B. NPrEP is a non-occupational post-exposure prophylaxis, so people will usually come in within 72 hours of their exposure. If they are given a form of preventative medication, they have to take it, and it must be taken for 28 days. And like anything else, it depends upon what type of exposure they have had and what is their risk. So, in other words, this didn't occur through sex. I went ahead and got spit on, or I was sharing a needle with another individual and I didn't know this is the first time this happened. So again, the different types of treatment that we have, very similar. And then post-exposure prophylaxis, this particularly um, is relevant to healthcare providers who in their work environments become exposed to an individual who is HIV positive. These individuals are going to get an initial screening for HIV. If they're negative, and we hope that they would then be placed on a 28-day course of a 3-drug antiretroviral regime and then be retested again at the end of that 28-day cycle. They need to seek care within 24 to 36 hours. 72 is the max in which we could potentially start PEP on them. And some other considerations, how to improve medication adherence. The same message is being spoken to by all team members, strong education, being able to provide them with resources for substance abuse and financial assistance in referring them over to caseworkers to help them. And sensitivity of the point of care testing. We really want to make sure that we are supporting them. It's usually about 2 to 5 weeks and high complexity testing between 1 and 5 weeks to really help these individuals. Again, doing this in the office, if they turn out to be positive, we do have to do that serum assessment. References that I've used. If you have any questions, please feel free to go ahead and email me. I hope that you found this information helpful.